Good morning to all. After the great success of complex coronary cases live series through heart.org over last 2.5 years, we as the Mount Sinai team, Cath Lab team, are pleased to announce a new series which will be done every fourth Wednesday, same 8 to 9 a.m. under leadership of the Director of Endovascular Intervention, Prakash Krishnan. Purpose of this series will be the same as to duplicate what we have been doing for the coronary intervention. That is to present a case, discuss some of the salient features and perform, and more importantly allow the participant to ask questions, and of course later on the whole case will be archived so that can be reviewed later on. With that note, I really thank all of you, those who have logged in, and of course this is the first of a series, will continue for many years to come, just like our coronary intervention. Therefore, I welcome our today's the participants as well as the moderator now, Josh Dangus, who is the Director of Endovascular Intervention at Mount Sinai Cath Lab, and he will start this today's session. And thank you.
Good morning, everyone, and welcome to the first live peripheral intervention webcast from the cardiac catheterization laboratories, cardiovascular catheterization laboratories, I should say, of Mount Sinai Heart. This webcast is going to be held monthly on the fourth Wednesday of every month. So the next one is going to be on February 22nd. This month's supporter is Medtronic, which I would like to thank. I also want to, just before we start, let everyone know that we welcome your input and your questions at the email address info@peripheраlintervention.org. In fact, it's a plural to make sure, peripheral interventions with an S.org, info@peripheраlinterventions.org. Please email us and we'll address your questions live on the camera and with interaction with the operators. And without further delay, I would like to introduce today's team. Dr. Prakash Krishnan, who is the Director of Endovascular Intervention and Assistant Professor of Medicine, Cardiology and Radiology here at Mount Sinai Medical Center. Dr. Jose Wiley, the Associate Director and Assistant Professor of Medicine and Cardiology, as well as Dr. Bruce Gray, who is a Director of Endovascular Therapy and Endovascular Intervention at the Greenville Memorial Hospital in North Carolina. I would like to welcome him to our cardiovascular catheterization laboratories. Prakash, Bruce, and Jose, good morning.
Hi, good morning. Good morning, George. How are you? It's really a thrill to start this off. I'm really thrilled to have our good friend, Dr. Bruce Gray, who came in all the way from Greenville, South Carolina yesterday to really kick this off in the proper way. Thank you so much, Bruce. So, you know, we're going to jump right into it because, as you know, time's of essence, and I'm just going to present the case. So if you can go to the slides. George, just let me know if the slides can be seen.
They're working perfectly so far,
okay.
PK, go ahead.
This is not the first slide, the one before this, please. Okay, so this is the first live case. A 69-year-old female, we'll call her MB from now, with a significant past medical history of non-insulin dependent diabetes mellitus, hyperlipidemia, hypertension, and an ex-smoker and an ischemic cardiomyopathy. She was status post PCI of the RCA in 2004 with a drug-eluting stent, and she also had a drug-eluting stent of the left anterior descending artery. She has a low LVEF of 20%, has been in and out of significant heart failure, presenting with acute renal failure. She had presented to the outside podiatrist with non-healing ulcer of the right heel, Rutherford class 5 with the Fontaine 4. And our ABI TBIs done at that time, our TBIs were basically 0.3 or 0.26, and ABIs were 0.45 on the left. She did have a Dopplerable posterior tibial artery initially on presentation. The medications you can see there, she's on all the right heart failure meds with carvedilol, clopidogrel, valsartan, so on and so forth. Go next, please. Dr. Wiley did the first peripheral cath. I'm going to have him just describe what he did.
Yes, this patient presented with Fontaine class 4 claudication and Rutherford class 5, as Dr. Krishnan indicated. When we did the angiogram, the patient essentially had dismal flow down into the ankle. The tibial peroneal trunk was occluded, as well as the anterior tibialis artery. At that time, we decided to intervene in the peroneal artery because it was the artery that reconstituted best at the level of the ankle. There was also a little collateral coming from the peroneal artery supplying the posterior tibialis. So at that time, we intervened in that peroneal artery and got it open.
So George, I just want to jump right in and just go over what we've done so far. So just for everybody out there, what we normally do in these patients is, obviously just we want to take an iliac angiogram to make sure that the iliac artery does not have any disease, or also to make sure that the inflow disease is not there. If you can put the angiogram up, you can see here that she has a robust iliac with a common and internal external system that's all open. I'm just going to play this again here. I'm sorry about that. And the catheter we use here is a universal flush catheter. For anybody starting out in endovascular intervention, you can use a regular pigtail, whatever it is that you have in the lab, to go ahead and do an iliac angiogram. But it's very, very important to define your anatomy prior to you intervening. Once we did this, we saw the arch was a favorable arch, and then we wanted to cross over. And as you can see here, the universal flush catheter which we use is actually a catheter with an end hole and also pigtail holes as well. So through that catheter, we used a very safe wire called what is it called? Tiger wire from St. Jude's, thank you, which has a very soft tip and a moderate support body. So you actually separate the curve of the universal flush catheter and then go ahead and intubate the contralateral iliac with the wire and actually drag it down so you don't cause any trauma to the distal aorta and then distally embolize any plaque to cause any problems. Also, these patients with these diffuse atherosclerotic lesions in the legs may also have ulcerated plaques in the aorta, so it's very important to be gentle as you go up and over.
PK, at this stage, let me just point out that this is generally a 4 French catheter you're using. And that do you start the anticoagulation just from this point, or this can be done without? I think that might be an interesting point to point out for those who are watching for the first time.
Absolutely. So what we do here, Dr. Angus, is go ahead and get the wire distal. We do not give any anticoagulation until we get our large sheath up and over. I'm gonna have Dr. Bruce Gray talk about that. But what we do is we go ahead and get this wire down into the common femoral. In this particular case, the wire did not advance any further, and that's really because of the transition zone. So at this stage, if you can see, we have the wire in the distal common femoral and it's trying to advance. It's like a push-pull technique that you use. Now, other catheters you can use in your lab, if you're doing it in a lab that does not have these catheters, you can use a Lima catheter, which we commonly have used, people have used in the past, which is readily available in most labs. But as the arches get a little bit more complex, you might need some specialty catheters. So here you can see that the catheter is not advancing over the wire, and so therefore we went to a Terumo glide catheter, and then using the push-pull technique, we go ahead and advance this up and over the iliac bifurcation. Again, notice I'm not allowing the wire to advance, which is very, very important because you know that you have the inferior epigastric artery and the lateral circumflex artery, which you don't want to perf. Obviously, if you perf the inferior epigastric, you can end up with a retroperitoneal lateral circumflex. You can have a rectus sheath hematoma. So it's very, very important to be cognizant of your distal wire, especially if you're working in a small camera. So I'm just going to I'm going to ask Bruce, as far as anticoagulation, which point do you go ahead and give anticoagulation?
I use anticoagulation as soon as I put the sheath in, I just use 50 units per kilo of heparin as a very cost-effective and a lower dose. And then if the case drags on beyond 45 minutes or an hour, then we rebolus.
So what we do here is, George, heparin is very cost-effective, as Dr. Gray pointed out. We go ahead and give bivalrudin because being in our lab, bivalrudin has really become the drug of choice in terms of anticoagulation. And there's been some safety studies done by Dr. Ali in Louisiana, which showed that bivalrudin is safe in peripheral interventions. But anyways, you can see here, we're tracking the sheath up and over. We still haven't given anticoagulation. Very important to watch the sheath go up and over. Be very smooth. Don't be herky-jerky as you're going up and over because you have a calcified aorta. If you jerk back and forth, you could possibly cause some problems. The other important thing is to use a stiff wire to take this over. We've actually changed out our Terumo glide here for a supercore wire, which has a floppy tip with a very stiff, Amplatz type body. Now that we're here, we've gone ahead and now we've taken our pictures, and I'll let Dr. Wiley just go over some of the pictures. SFA.
So you're going to be selective as selective as possible in order to get high-grade pictures when you deal with infrapopliteal. And as you see very clearly in this picture, the sheath has been unvased selectively to the proximal SFA. Therefore, there isn't much dye going into the profunda, etc., creating a non-visualization of the below the knee arteries. We will see it very clearly as they come up.
Correct, and here you're going to see the SFA, the distal portion, and filling of the popliteal artery. It should be coming soon. Here we go.
So she has a moderate lesion in the popliteal, which really wouldn't be causing any of this. And you can see here the work that I'm sorry, we had a little trouble with her moving, so we were trying not to make her move. So you can see, which is in a little bit of pain, but she's well sedated now. So you can see here that with the TP trunk that Dr. Wiley opened, there's a moderate a narrowing, and then you want to point out the vessels, Jose?
Yeah. So in the medial portion of this image, which would be to my right, you're going to see a trickle vessel, which is the posterior tibialis artery. The one in the middle is the peroneal artery, and the one that is most lateral, in this case, would be the anterior tibialis, which you also see occluded. Now, you may be asking, why is she back here again if we had intervened on her 3 months ago? She's here again because she had a non-healing ulcer that we tried to intervene at that time. The ulcer never healed. It did not get worse, but it did not improve either. For those of you who are familiarized with the concept of angiozones, we decided to intervene at that time in the peroneal artery because there's a calcaneal branch that comes out of the peroneal artery, which particularly feeds the lateral portion of the heel. Obviously, this has not improved significantly, so now we're going to try to intervene in the posterior tibialis, which is calcaneal branch, will feed the medial aspect of the heel.
So you can see in the last shot here, you can see that the peroneal artery gives rise to a robust collateral, which supplies the posterior tibial artery in the foot. And I think that was the plan with her being in renal failure when she first came in. So anyway, as far as our plan, let me just get to the case because time's of essence, and then you guys can talk. We've gone up and over with a mailman wire, and as a support catheter, we chose to use a Terumo fine cross. So right now I'm going to go on live fluoro. As you can see here, I don't know, it's kind of grainy. I don't know why it's so grainy. I'm just going to, there it is, a little better. So we're going to we have the Terumo fine cross in the posterior tibial artery, and now we're using a glide catheter. I'm just going to ask Bruce in terms of what his approach would be in these kind of cases. I'm just going to start working.
A great case. Notice that they've doing this from a contralateral approach. Typically, if you're trying to get to the foot, there's a good advantage to come antegrade from the common femoral artery down. That allows maybe better pushability and torqueability of your wire. We'll see how they do here as they come in this contralateral way. The other alternative form is to put a longer sheath in so that the sheath extends down into the popliteal artery. Sometimes that gives a little bit more support. So you can see he's being very careful here. And I think that's really important to begin with, using a soft wire, and if this one doesn't cross, he'll gradually walk up to more stiffer wires, and that's been our practice as well. The support catheter that he's using is very small, so that it will track over the 014 wire, and so this is our standard technique as well, and there's a lot of different catheters that are available to try to do this. So
now, we're getting some questions here from the internet webcast attendees. May I ask you, what is the appropriate non-invasive follow-up, or non-invasive, workup before you plan this case? What can be done non-invasively in order to better understand the targets and the aims of the procedure here?
George, that's a really good question. I'll tack that as they're working away here. Our standard approach would perform an ankle brachial index to begin with. certainly, and then also complement that with duplex ultrasound. The use of CTA has improved, but for tibial, the defining tibial arteries, it's been less useful. Some people use MR and MRA as a study to look for smaller branches that don't necessarily fill, at least arteriographically, or you don't see them with great flow with duplex. But our typical approach would be to do an ankle brachioindex, look at the toe pressure, as well as with duplex ultrasound, and look for some hibernating vessels.
So the toe pressure is a good, I think, tip, because it's not exactly the ABI. Now, may I ask you any features of the ulcer or the location of the ulcer that may make you select one versus another target, or define a little bit better, understand a little better the etiology of the ulcer?
That's a great question, George. I think the angiosome concept that Dr. Wiley alluded to is really what we use here. I don't know what Dr. Gray uses in South Carolina. I think what we try to do is go by that. I mean, at all costs, we try to obviously get straight line flow into the foot. Unlike this, only problem with this lady was obviously she was having acute renal failure at the time. But most of the time, we just try to use the angiosome concept here.
Which is?
And maybe we can just expound on that just a little bit. The basic principle in somebody that has an ulcer, a ischemic ulcer on the foot, is to get direct blood flow right to it. And each of the 3 tibial vessels perfuse different segments of the foot. And when you're looking at a lesion on the top of the foot, well, of course, the anterior tibial to the dorsalis pedis artery would be ideal. When you're looking posteriorly, then the posterior tibial artery would be perhaps more advantageous. The reality in our interventional procedures is what we typically do is look to the foot first and see what feels the best and try to get to that through the easiest channel, which is exactly what Jose did, which I would agree is the initial endovascular approach. As he described his thinking process before, he had a lesion in the tibioperoneal trunk peroneal artery that was amenable to routine intervention, and he was able to reestablish direct flow to the ankle, and then he had a big collateral to the posterior side of the foot, rather than trying to attack the most complicated lesion here in the posterior tibial artery initially. So I think the angiosome concept is helpful, but yet I think you have to take what you're given initially. Does that address that, George?
No, I think that was a very good. Yes, I think we have in the webcast we always have a disparity of different levels of many attendees, and their knowledge, baseline knowledge of these types of procedures may vary. So it's great to kind of elaborate a little bit more on what we mean with the various comments.
So technically here, the fielder wire would not go. I tried to be as delicate with it as possible. So now I'm just going to go advance a stiffer wire here, which is the Confianza Pro. I am a little concerned because I have a little bit of resistance in my catheter. I'm just worried about whether we have any clot. I think I may pull it out. We may have some clot inside this catheter while we were waiting. Yes, we do.
Are you going to use a 9 or the 12 gram Confianza, or it doesn't matter?
We always use a 12, George, and as we go. Give me a mailman again, guys. We always use a 12 as we go. I figure that most of these lesions are so calcified, yes, and we do have clot in the little catheter that happened. It was basically 411.
So let me take a minute while they're flashing the catheters to explain the different wires used thus far. The Mailman is a strong body wire with a non-hydrophilic tip. That was the workhorse wire for the peripheral intervention tried first. That didn't advance that much, and that was substituted by the fielder wire, which is a hydrophilic coronary wire used to cross occlusions with microchannels. That did not work very well, and the third one now is a Confianza Pro that is a stiff wire with a non-hydrophilic edge but a hydrophilic tip, just few millimeters proximal to the non-hydrophilic edge. So when you're against the lesion, it's not hydrophilic and steerable, but then there is a segment, this the more the black segment of the wire is more hydrophilic and allows you to avoid the friction with the hard calcified elements of the plaque. And as you see now, they're navigating the wire from the tibioperoneal trunk in order to engage into the posterior tibial. There is a residual lesion in the tibioperoneal trunk. I wonder if, I guess it looks sort of okay with the balloon angioplasty first time around. I wonder whether that might be a candidate for a stenting and maybe a use of a drug-eluting stent in the very end of the procedure. Bruce, what do you think about that? The lesion that they just crossed with a wire.
Yes, I think their plan is to address that, and I like your consideration of a drug-eluting stent. The Destiny trial that's just been published certainly has shown that in a randomized comparison between drug-eluting stent and bare metal stent, that the drug-eluting stent was a big advantage in regards to patency and also lack of TLR. I think their TLR rate at 1 year was only 9%, which is outstanding.
Is there a difference? Might there be a difference between drug-eluting stents in this quest, Bruce, or you think the coronary data might be on neointimal hyperplasia suppression, where the different stents might be just as good to go by?
Well, in the periphery, the drug-eluting stent concept is been really poorly studied, but I think with the Destiny trial, the proof of concept is there, as well as some randomized data to suggest that drug elution does work in the periphery, but maybe it'll take a little different dosing than what's seen in the coronary for the most ideal results.
Interestingly, George, a lot of the data, at least from my reading about it, and want to ask Bruce's opinion on this, is that the Taxus stents seem to be associated with a little bit more stent thrombosis, like they were in the coronaries, and in the peripheral, it seems that that also holds true. As far as in our experience, we've done about 35 drug-eluting stents so far, and as Dr. Gray pointed out, I can have the confianza? As Dr. Gray pointed out, it really works where the patencies are phenomenal. We do follow all our patients, and actually Dr. Luchstein presented this at I believe the Society of Interventional Radiology about 2 years ago, and I believe has written it up. I'm not sure. So the point is that I think that we do use it, but my worry is the cost, who's going to pay for it, and those are all real issues.
Great. Now, since we're talking about stents and still in the wire exchange, let me just follow up with a question from the audience. What do we and how do we address the issue of dual antiplatelet therapy, whether a drug-eluting stent is placed or not? So let's say we have a balloon angioplasty or a drug-eluting stent. Is that in the periphery? Is dual antiplatelet therapy mandatory for the balloon angioplasty or kind of optional? And how does that apply in these types of infrapopliteal lesions, PK or Jose or Bruce?
Well, I can tell you what we do, and I'll have Bruce address what he thinks. You know, as far as at Sinai, we go ahead and give dual antiplatelet therapy for these lesions with aspirin and Plavix. Now, this lady obviously has ischemic cardiomyopathy, has multiple stents, and a lot of the patients that we deal with have that same problem. But in a patient with isolated vascular disease, it's certainly very interesting in terms of what Bruce's thoughts are. How long would he go ahead and give the dual antiplatelet therapy?
Yeah, I leave them on as long as they can afford it. In South Carolina, that's somewhat of a problem, is being able to afford the dual therapy. But maybe once generic Plavix is available, then that'll help a lot.
Yeah, in my opinion too, in the infrapopliteal severe diffuse disease of this type of cases, dual antiplatelet therapy would be critical for a long term, regardless whether you put a stent or no stent, because the disease is so diffuse and the vessels are small and long, and you know this type of lesions are prone to recurrent thrombosis and all that regardless. Now, when you go into the more proximal segments and maybe shorter lesions treated with a stent even, non-drug eluting, maybe really the dual antiplatelet therapy is less mandatory for an isolated iliac or other lesion, for example. And so we should keep that in mind.
I agree, George. I think, and the periphery is different than the coronary circulation. Our restenosis rate in tibial vessels is extremely high. So anything that you can do to improve upon it, and certainly the Japanese have used triple therapy with the clopidogrel and showing lower restenosis rate.
And cilostazol, yes, exactly. And I must say that the cilostazol has been shown to decrease neointimal hyperplasia within coronary stents, both by angiography and IVUS in repeated studies with bare metal stents. Of course, it's not used as much since mostly the majority of stents used now is a drug-eluting. But if someone is dealing with periphery and you really want to target neointimal hyperplasia, this agent has been shown to decrease neointimal hyperplasia following percutaneous intervention in other vascular territories, and therefore might be useful. Again, you see the difficulties of support and advancement of the confianza wire that PK is trying now to slowly advance straight down from the end hole catheter, which is the fine cross. And
we're being very gentle here, George. It's been very difficult to really navigate through this occlusion. So what we're going to do is just take a picture to make sure our pathway is something that everybody agrees with. Inject. Now, you know, it's important to talk about what are the other options if we're not able to get through from the antegrade approach. One of the things that we may attempt to do is, and she's moving again, is to come retrograde through the collateral, although this is starting to look a little more promising.
I think it sounds like you have a good shot there if you're going straight, I think, in this.
It looks like it. What do you think, Bruce?
Yeah, I'm a little bit concerned of how much wiggle you had at the front of your wire, and I know you were bothered by how this wire, if it's in the lumen, it shouldn't deflect very much. The more it's able to wiggle, then the less likely you are where you think you are. So I think that was your concern. I noticed you're hesitating, or you're being very cautious there. So we'll watch it and as he continues on here and see how it goes.
Now, it's also important, as Bruce was saying, just to take multiple views. And see how Bruce is saying, see how this wire is just kind of wiggling everywhere? And I'm a little worried about it, and that's why I'm not really advancing my my Terumo fine cross down along with this. Now, if we do, I don't really think we're going to cause much issues because it's a very, very small catheter. So I'm just going to try to go down with that fine cross down.
PK, would you do us a favor and collimate a little bit more?
Sure.
Because this is going to increase the how good our picture is on the screen.
Okay,
great,
I got
great,
it now.
Great.
Now the other thing is, now I just came down a little bit. Now I'm having a lot of resistance going down, as Bruce was saying. Now that could be because the artery itself is so occluded, but this kind of bend that I'm getting on the vessel is not something that's very favorable. So I'm going to pull back again and try in another plane, hopefully. If not, we may just go retrograde transcollateral as we talked. Yeah, that looks a little bit more interesting. Let me try to go back down. It's always important to come back and forth and try to find the plane that's favorable for you.
Would you maintain the wire from above while you are going retrograde from below in order to guide yourself?
I probably would here, and that's what I'm going to do. I'm going to stop here, and I'm going to come from retrograde. I'm going to go ahead and just ask for a field of wire, guys, and another fine cross. Actually, we can work this one out. Yeah, we can work this one out. What do you think, Bruce? Keep trying or go retrograde?
I'd come around.
Yeah, you come around, right?
I like
wiggling too much up there.
Yeah, I think exactly where the wire wiggles, this may have deflected outside the lumen. The lumen should be generally kind of straight line in that segment of the leg. We have a question regarding the patency, the primary and secondary patency of the infrapopliteal intervention for focal and separately for diffuse lesions. What's your opinion, Bruce, nowadays?
Well, a longer lesion in a tibial vessel would be 4 centimeters or greater. So, in the 1-year patency rate certainly would be in the 20% range. It's quite low with straight standalone angioplasty for longer tibial lesions. The shorter, more focal ones are very good, and I'll show some data in the talk that we're going to give after this live case, where the the actual destiny stent data in the tibials, which has greatly improved upon that. So, but the average lesion length in destiny was only 2 centimeters long. So, our long-term results with longer lesions is not good.
Yeah, at the same time, I must say that even transient patency may lead and allow healing of the ulcer.
Oh, yes.
So that is something that I think we got to make a little bit of a distinction, because infrapopliteal intervention is done for tissue loss. Maybe a few months is okay to be open in order for the ulcer to heal, and then we'll see what's happening.
And it does matter how big the ulcer is, George. That's an important point, because the healing rate is about 1 centimeter squared per month. So if you think your intervention, if you can get 3 months out of it, you can get about a 3 millimeter squared ulcer to heal. If it's a bigger ulceration, 5, 6 millimeters, then that's where some other strategies may make more sense. And there's some emerging data on that with Dr. Neville. I'll try to show a slide in regards to what his results were with the size of the lesion and whether or not he used surgical techniques or endovascular techniques.
So essentially, now for the audience to explain the phase of the procedure, the peroneal artery has been cannulated all the way with a fine cross catheter that follows now, and the filter wire, which is a hydrophilic wire, that is going to be deflected medially towards the collateral, that then communicates with the posterior tibialis artery, and then deflected upwards towards the proximal part of this artery. And you see very clearly now our target collateral at about 5 o'clock. I'm sorry, the camera moved, so we lost the fluorophase. Okay, excellent, much better. Okay, we made the loop very well. And
so George, you can see here, it's very important to go with a hydrophilic catheter to make the turn. Now, it's also very important to be cognizant of how important this collateral is. I mean, as much as we want to recannulize everything from retrograde and proximal and all these things, you know that there are other modalities for this patient. You know, I do realize that nobody wants to, offer anything with their cardiomyopathy, but we did discuss with the surgeons a few things, and there are other options. We've tried hyperbaric oxygen therapy, obviously, with her. Let me show me above, please. So what we want to do is advance slowly. Now you can see you got the wire above, wire below. Do DSA, please. I'm going to inject from below. DSA shot. Ready, inject. So what we're doing is we're injecting, and now I just want to, again, get a pathway, and of course I've got the luxury of having Dr. Gray here and Dr. Wiley as my patient is moving, just to see which way we're heading. And I think it's pretty favorable. It looks pretty favorable right here. And I think if Bruce is agreeable, I'm just going to go forward with this wire very gently, trying to just try to snake it forward. Seems to be moving very nicely, and there's a little medial deflection. These are very difficult cases. They're chronically occluded for a long time.
I wonder if you would change now to a stiffer occlusion wire or not yet. What is your decision-making point for the retrograde wire to become a Confianza or a Miracle or something like that?
That's a great point. I usually try with the soft wire just to see, because the cap is a lot softer below than above. I don't know if Bruce has got that in his experience as well. And try to go through. Again, it's very hard to torque these wires, and part of the reason what Bruce was saying about a antegrade approach might have been more favorable here. But let's see. I think here you can see the cap is quite hard, so I'm going to ask for another Confianza here. Bruce, what is your?
I agree. I think I think starting out with soft wires, and you can change the penetration power of the wire. Penetration power is defined by the diameter of the wire and the diameter of the wire as well as the tip stiffness. So the higher the tip stiffness and the smaller the wire, the higher the penetration power. And if you put your catheter close to the end of the wire, you can greatly increase the tip stiffness and thus its penetration power. So the closer the catheter tip is to the end of the wire, even with a stiff wire, you can greatly escalate it. So, and that's what he's asking for here. He wants, and you can change the the penetration power just by having your catheter very close to it. And you see how he manipulates the wire and the catheter to get the kind of feel that he's looking for.
Now, having said that, I mean, clearly what Dr. Gray said, the antegrade approach here might have given us a little bit more torqueability, you know, and I think it would have, actually, not might, would have. Problem with her is she's, as you can see, very uncooperative, she's heavily sedated, has a lot of pain in this leg right now as we're doing this, so she's complaining to our nurses. So what we're trying to do is do the minimal thing. The other options could be is coming from a pedal stick. Obviously, those are things that we could try here. She's moving again. No te muevas, señora. So I'm just going to try to be very gentle and try to manipulate this up, and let's see how it goes.
Yeah. We have another question from the audience. What might be a surgical alternative or a surgical option in a case like this?
Mm-hmm. It'd have to be a bypass into the plantar arch there, because the above knee segment's rather small.
And the success of the surgical intervention is always related to the size and the location of the distal target. So I would, in my opinion, that would be a tough one to expect great patency in the end.
And the quality of the conduit. So if you don't have good vein, and you'd like to see a 3 millimeter vein, if possible.
Yes, that's another good point. Evaluation of the veins might be very critical in that, because perhaps if there are no good veins, then I don't know that a PTFE conduit or other conduit would be acceptable here.
Agreed.
So that's another non-invasive testing one can do before the procedure, before even this procedure, in order to evaluate better the surgical option. You scan for veins in the lower extremity. If there isn't a good quality, then you would upfront consider this the surgical option of a patient perhaps quite suboptimal.
Now, George, I've tried to go from below. The catheter is not advancing because, again, of the calcium, the lesion so calcified. So over here, what I'm going to try to do is, while they're getting another catheter called the Corsair catheter, I'm going to try to just see how far down I can try to meet the two wires if I can.
Yeah.
This one seems to be going more lateral, and hopefully, maybe make a little bit of progress.
This is a control antegrade and retrograde tracking, the so-called CAR technique initiated in the coronary, but I think it's this is a great example of it in the peripheral. Most wires are moved in a way that even though subintimal, still the space can be found. So in order to facilitate that, one could perhaps dilate in the proximal area in order to make the target of the distal wire a little bit better, a little bit more doable. I was gonna ask you, PK, you already mentioned Corsair. I was gonna ask you about other end-hole catheters besides the fine cross. So Corsair is another one, is a little bit more steerable. What other options exist? Are these the only two?
Well, that's a great question. As far as 014, we've been lucky enough in this lab to be able to learn a lot from our coronary colleagues, and learning the the transcollateral approach in the coronary from Dr. Sharma, yourself, Dr. Kinney, so on and so forth, has really we've been able to translate some of that. The Japanese, obviously, as you know, George, have used these two catheters extensively in the transcollateral approach for the coronaries. And we've been using it with great success in the peripheral. Now, for those who don't have it available in their lab, then I think the issue becomes is what can we do in terms of other modalities. Now, you can try the 014, what is it called, as a Spectranetics quick cross. Unfortunately, the crossing profile of that is not as good as these. So it's difficult to push. You can try a balloon for balloon support. Again, the same problem will occur with an nanocross. And other balloons like the Armada or the Ampherons from Medtronic. You can try any one of these balloons. But here what I'm going to do is I'm going to have Dr. Wiley work from below. I'm going to come from above and see whether we can just try to meet our wires. I mean, just see how it works here.
Does the support catheter, the retrograde support catheter, advance any further?
I'm going to try right now, George. Hang on, as Dr. Wiley rails it. Rail me, Jose. Show me down below, guys. Let me see the support catheter. Okay. And rail, please. It's bending up top. It's not railing? You're not railing because it's bending. Okay.
George, we'll sometimes use Terumo makes a ProGrade catheter which has a fixed glide wire inside a 028 or an 024 catheter that we'll use down here sometimes. Cook makes the CXI catheter that is quite small and traversable, and then there's other catheters like the Renegade, that neurointerventional type catheters that have slight curves to the front end that are quite helpful in getting into these small arteries.
Great. Let me just point out that there may be a contribution of maybe a little bit of a spasm as well in this collateral that may creating some problems with the end-hole catheter. I think PK is going to substitute that with a Corsair catheter right now.
The Corsair catheter is a great catheter. I don't know exactly who makes it. I know it's marketed by Abbott. The catheter itself is basically like a corkscrew in nature, and it works quite well. We've learned in the coronaries, getting to the transcollateral approach, it's worked quite well. So the cost is a little bit higher than it is for the Terumo fine cross, at least in our lab. So we go ahead and use that as a secondary catheter once we're not able to get the fine cross down. So right now, Dr. Wiley's walking this out. I mean, we're pretty close. And, these are very difficult cases and can take a little longer. So we're just trying to work as fast as we can to try to get this done.
This is a fascinating case. And again, if you can, in the bottom left of our screen is a little bit, if you could collimate just a little bit more, because that blurs our image here in the screen.
Is that better, George?
Yeah, that's good. That's good. Yeah, good.
Okay.
Good. Perfect. Now the.
So now we're going to introduce the Corsair in, and we're gonna go ahead and try to get closer as we're going up. The wire was certainly going, but unfortunately the catheter wasn't tracking.
Yeah.
And these are common problems that we face, and that's what takes longer with these cases. But let's see, we'll keep working here.
Now another wire you may want to ask to have them in the room is a progress wire.
Yep.
That may be an option later on. But.
Yeah, and I think that's going to be the next wire I'm going to ask for. And in the peripheral, they're not called progress. It's pretty much the wires coming back. They're pretty much called show me the catheter going down. They're called another lower. Oh, no, it's still higher. Okay. They're called. Tip of the wire. I'm just going to take this down. Now it's very important to rail the way Dr. Wiley's railing, because you're in a collateral, and there you can see the catheter come down now, if you can see through his hands. Turn this side, Jose. Show me above. Very important to try to get the catheter smoothly to the collateral. I didn't feel any resistance going through the collateral, George, so I'm not certain that we have any spasm going on.
That's great. That's great. Yeah, the Corsair is a good catheter for that, and you see that with a little bit more support, just supporting the wire a little bit more with a catheter, you're probably going to make the last final few centimeters here.
Now you see the Corsair seems to be advancing easier. Now we're just going to try, and we still got a long way to go here. I know it looks close to that other wire, but the issue becomes is how close are we in terms of the
lumen.
Yep, exactly.
But even if it's within the perivascular sheath, within the adventitia, not within the lumen, we can create some kind of a bridging there. But we'll see. We'll see. We'll see.
Yep. I'm just going to try to advance it a little further, and you can see I'm really able to advance it. I just didn't like that curve that took. I don't know if everybody kind of noticed that.
Yeah, clearly it does deflect a little bit more than Bruce would like to see here, I think. But, this is how it is. Let's see where it ends up.
Yeah. Yeah, it's not. Yeah, you know what? Give me a fielder again. Let me work with the fielder. I'm going to go back to my hydrophilic wire so I don't create too many perforations of things here. So I'm going to try to work with this through the Corsair.
Anything else?
And this is very important because, as you see, you want to go back and forth. Give me a wet one, guys. Thank you. Huh? It's called, I think it's called the wind wire. Get me the wind wires, guys. I know we have them, which are the progress in the peripheral. Well, that's a good sign because I'm probably in a little collateral there. I'm going to try to advance this a little more. You can see the calcium. I don't know how it shows to you guys, but you can see there's a lot of calcium there. Huh?
Well, I mean, the vessel is diffusely calcified.
Why?
And has multiple stenosis, so it goes without saying that this is very tough to keep it in one place.
The magnification one. Let's see.
Okay.
How
So
about we
give me the wind wires.
how about we up your magnification a little bit, see if we can see the fine detail.
Yep, absolutely.
Since you're, yeah, that's great. Look at that.
So you can see here, I'm going to just try to rotate back and forth, try to see where we are. And it looks pretty, you know, we're on plane. We just need to get through this little last distal cap. Can I have the wind wire, guys? Now the wind wire, as you know, it's the progress, George. You need to just describe it for what it is. It's obviously a graded tip wire, right, George? Like the progress.
Yes, it's a graded tip and has a greater gram stiffness than any other wire. And the question is the ability here to penetrate in a straight line. That may have more of a role because you know, obviously the coronary CTO wires have to negotiate more bends, avoid bifurcations, etc. Here, what we're looking particularly in this case, we're against a largely straight vessel that has severe diffuse disease and calcifications. So the pushability on a straight line of the wire is very important, and the gram capacity of this wire may be of help.
Yeah. And this has got a harpoon-ness to it. It's quite a penetrating wire.
Yeah.
Just give me the torquer.
Because it
Give me
has
another
that
torque, guys.
transition. There's also a new line of wires coming out from Asahi that are 0 and 8 called the treasure wires that have that trying to create a big support type wire, but has crossing capabilities, and they come in a variety of different gram tip strengths. And another wire series that we hadn't talked much about is the 0 and 8 glide wires. The glide wire gold has a kind of a front tip on it that's fairly friendly, so if you're going through stenotic disease, it's an outstanding wire.
We're just going to take another picture to see whether we see anything. Inject. So we want to see the plane where we're at. And again, with our, we need to go DSA, guys. With our cardiomyopathy, you know, her blood pressure is up and down, so we're also monitoring her. One of the advantages of where we are, obviously we have inject. See, it's just going to take a little bit of work to get through this. You can see the amount of plaquing that's there and a real calcium right there. We're right by a collateral. So we just need to keep going straight and try to meet the two wires. So I'm going to go ahead and keep working here.
I think this is a very hopeful picture, though. Looks like if you penetrate this the distal cap from the retrograde approach straight up, it may be very hopeful.
See, again, as we talked before, the movement of the wire is kind of worrisome. I don't know what Bruce thinks, but I don't like the way that's moving, Bruce.
Yeah, and your hand's telling you something too, how much force you're having to put on it.
Exactly. I agree totally. So might pull down and try to find another plane here. Try to come. The problem is once you've created the plane, it may be an issue.
Well, one thing is for sure, if there is a lot of resistance, this is a true lumen.
That's a good point. Actually, George's point is very good, that it is a true lumen.
If you have a lot of resistance ahead of you, this must be true lumen.
Now, you know, Dr. Wiley made a great point here. We want to angulate in a different plane to see how we are. And now he's going RAO, and we're trying to see how far away or how together we are. Lower, please. Lower, please. Right there. A little higher. So you can see here, how it seems to be in a different plane here. So we're going to try to reorient this.
Well, it's interesting though that although this deflects upwards and to the left, the antegrade wire also has deflected downward and again to the left.
Right.
So there may be some vessel angulation there that because both wires seem to be angulating towards the medial aspect or the lateral aspect of the vessel, I should say.
Maybe the other wires are on the right.
Show me both, please. Now I'm just going to take a shot without advancing my quick cross. Inject. Now we want to see the flow from above, see whether we can get an idea where we are. Obviously, we're occluding with the wire prop in all likelihood, so we may have to pull the other wire out to really see where we are. But I'm kind of like the way the direction this is going now. What do you think, Bruce? Should we keep going up or?
I agree with you.
Right? It seems to be moving much freer,
I agree.
and definitely, you know,
We may have been spent upon the.
let me pull the other wire back here.
I would.
Okay, let's take a shot from above. Right, do it again. Uh-huh. You can see the distal end of the vessel there.
Not sure what's going on over there. I mean, we're not very well oriented from where we are.
Well, what we're actually looking at is a very magged view of the tibial artery.
But also you're angulated at 27 REO, so it's not comparable to our previous views. So it's not so easy to follow from here.
Got it. I'm going to track my catheter up now. Show me down. Uh-huh. Okay. How are we doing on time, George?
You have at least 10 minutes for.
Okay. Nope. Mm-hmm. Let's go to lower mag here. Oh, okay. Inject. Seems to be, again, we're going to keep going up. I just can't, I'm not able to track anything up or down, which we're really having a hell of a time here trying to move this both the crosshair as well as our fine cross.
I think that the antegrade wire still is in the anterior tibial, so maybe it'll obstruct some flow there.
I can pull it back a little bit more.
Or maybe we could put a little contrast down through the catheter that's in the proximal portion of the posterior tib. Just a little local shot. See how close they are.
So Bruce, would it be mandatory that the true lumens meet from above and below, or would you accept that the wires meet in outside the true lumen?
Doesn't matter. In my mind, the Germans will put once the wires kind of crisscross like this, and if they don't meet, then they'll dilate with small balloons on both sides to.
Exactly. That's what I was thinking about. That right now, crisscrossing the wires. Perhaps you can put some balloons there, or maybe you can just put a balloon from above, dilate there, and then see if the retrograde wire can fall into this dilated area.
Well, I mean, to me, I think I'm not really comfortable on where these wires are. I mean, I think the above wire is more comfortable than the below wire right now. So I would just kind of feel at this stage to try to keep working and try to go up towards the true lumen. Obviously, we have a wire down below. Just a matter of trying to keep working it up. I don't quite want to go ahead and dilate at this stage. Let me just see how far this goes. I know we're running on time, but yet at the same time, I just want to do the right thing here as much as I can before I...
Yeah, I wouldn't worry about the time. You're right. Let's concentrate on the case. Let's not worry about the time. Anyhow, this will be archived at the website peripheраlinterventions.org. And obviously that will include not only the live case time, but also the final result of the case, even this is achieved a little bit after the 1 hour window that we have available for the live case. Again, for the viewers, you can email us your comments at info@peripheраlinterventions.org.
Very close.
And the website is www.peripheраlinterventions.org. Remember, this is info@peripheраlinterventions.org, includes an S, it's in the plural, interventions in plural.org.
So you can see I have a little bit of a fistula with probably a little microperforation. Obviously, these things do happen. I'm not really concerned about that at this stage. I just want to try to see how this
How would you handle the angiomax with respect to this now? As we know, the angiomax, and I'm going to actually, while you're working, I'm going to give a little bit of a review of the angiomax and what it does and how it works, the bavalirutin. But would you stop it now or would you continue it?
I just want to see how this wire is now moving really smooth. I just want to see whether it goes up like I think it's going to. You know, it's one of those things you just got to say, yeah, now this is looking really sweet here. If I can just get it up a little bit further, and we can snare it and do what we need to do. Oh, it's going immediately here. Now, I would just ask them to turn off the Angiomax at this stage.
Exactly.
Because, you know, ACT is high. Yeah. I'm not so concerned. Turn off the Angiomax, guys.
Yeah,
which they're going to do right now. And I'm just going to watch her carefully. Inject. Oh, she moved. No te muevas, señora. Oh, we're way off, as you can see again. So, you know, you see how easily you can get fooled. Come back down, guys.
Yeah, so just the bavalirutin is a direct thrombin inhibitor that works with a fixed weight-adjusted bolus and infusion. Has been well characterized in many coronary trials, including unstable angina, PCI, and ST elevation MI, and has a half-life of about 25 minutes. By turning it off within about about 30 minutes, most of the effect will be gone, and within an hour or so, almost entirely the effect will go away. And as you know, we're also, as you can notice, we're also largely occlusive with our wires and our equipment in this area of possible microperforation right now. So this would be the absolutely correct choice from PK to keep working. And he knows that from now has a you know an allowance of about a half an hour or so, 40 minutes. That there will be still some anticoagulation, but not much. It will be continuously waning down.
Right, do this as the Forosave.
And he can continue work, but at the same time be somewhat protected from the perf by interrupting the infusion and starting the auto-degradation of this drug, which is, by the way, metabolized by the plasma esterases into a non-active form. It's not 100% dependent on renal clearance, etc. Of course, those fragments are ultimately cleared by the kidneys. However, the effect is gone after the metabolism by the plasma esterases.
Yeah. Again, we're just trying to redirect the wire here, George, and hopefully it just sneaks in. I mean, we've had some luck with this progress at this stage here. I think this is the problem. I think we're probably on top of the vessel here, Bruce. What do you think?
Yeah.
Well, if you're able to, if you are where you think you are, then perhaps advancing the microcatheter and trying with a filter might also give you an edge here, because above there is a line, you know, there's some kind of a channel. So if you are indeed in the lumen below, you know, maybe the hydrophilic will engage, you know, all the way from here.
No, she's moving so much, and probably have to look at the picture.
Yeah, she's moving a lot. I mean, I may go with the fielder here, like you said, George.
Yeah.
So can I have a fielder wire here, guys?
Yeah, advance the microcatheter so it's at least overlapping to where you still see some lumen there, and then maybe the fielder will get you home.
So the microcatheter is actually quite a ways up. I'm just worried that I'm not entering the right way here. So I'm going to try to go with the fielder here and try to see whether I can get it into the lumen. See, it's so smooth now, which is kind of concerning. Let's see how smooth it is. I'm probably in a nice subintimal plane, but let me try with the fielder.
Yeah.
Any thoughts, Bruce, here on what else we could try here?
And coming back down from the top, I wouldn't give up on that
Right.
direct approach either. Because you've made some, you have a subintimal plane from below,
right,
through part of it at least. And
The Lord?
Yeah, Bruce, would the 018 glide wire have any role in this case?
yeah, that's where I like that glide wire gold.
The glide wire gold, that's right, yeah.
I like that a lot, and that's why I like the Retrograde catheter wire combination. It's very nice.
So the Retrograde catheter with a glide wire gold 018 wire.
Yeah, it has a regular glide wire and not a glide wire gold, but I'll sometimes swap out the wire just for the gold part of it.
Oh, I see.
No?
They come in 40 and 70 degree front angles. I just use the 45 degree angle.
Right.
It's doing the same thing here.
I think this is exactly where it was in the beginning.
Give me the...
And
When we first stuck in the first go around, this is the same.
and a comparison wire to the fielder may be the run through.
That's a great idea. Run through may be an idea too. But I think here we're gonna, you know, just to illustrate, obviously this, we wanted everything to be a success, but right now we're working. I'm not saying this is not going to be a success. We're just working and seeing how this is.
It may be a lot difficult to finish this within the window of strictly 60 minutes, but still there is ways to go until 9:45 when the bavalirudin effect will completely go away. And you know, that may be quite some turns until then. That may, this case may actually be successfully completed by then. Now this is a filter wire advanced from below.
Now I'm going to try to advance my Corsair, which is coming up nicely. Can I have a torque right here, guys? So as we can see here, we're gonna try to see how we are. Again, it's the section plane is quite large, so we're gonna try to keep working here, trying to see whether we can somehow sneak it in and meet the two wires. Obviously, above is the plane where you said, George, where it initially ended. And again, you can see here, it just does not seem to want to go here.
Yeah, there seems to be a very hard plaque location right there.
Yep.
That is very difficult to navigate from above, and somehow we're having the same difficulty from below. So this is just one
I don't want to go any further.
about a 20 to 25 millimeters of vessel that is completely hard and calcified, and it's difficult to navigate. That's probably where the true occlusion is. The true occlusion is right here. And
Yep.
there is a subtotal occlusion until then from the proximally, and there is a less hard total occlusion in the distal part until the collateral comes in.
And I'm just following what Bruce was suggesting, which I think is a great idea. Try to work from above and below, and just try to use a little bit of movement on the catheter. But right at this point, you know, as Bruce said, it's the ability of this catheter not to, this wire, this cap not to yield.
And again, we had the RF ablation catheters and other catheters try to navigate these types of lesions for the coronaries and the peripheral. I mean, great ideas, nothing much ultimately.
Yeah, you know, that's another point. Bruce, have you tried the ablative catheters with the RF and stuff? Have you tried that?
Not here, no. Not with tibials.
How about the crosser catheter?
Yeah, no. I'm basically the software type of.
Yeah, you're like us.
Yeah, I mean, it's a little difficult. I mean, those approaches maybe have tried in the femoral and popliteal arteries. In the infrapopliteal vessels are really small. It's very apparent to everyone who's watching this case that there is no good way to know where the majority of our wire is right now. So if we were to, let's say, substitute this wire with an RF ablation wire, we would really have a dilemma of where we are ablating, really. So, and that is, that's really the limitation of this.
Well, right now I'm really having a dilemma on when to quit and what else should I try on this patient. You know, we could stop here, bring her back for a pedal stick tomorrow, obviously with her creatinine. That may be what we decide to do, and see how she's doing. She's obviously in a lot of pain from prior in the beginning of the case, and see what else. I can see this wire is extremely sticky, and just trying to maneuver it is very, very difficult at this stage.
Do you want to take a picture there and see if we're closer?
Well, you know, I mean, Dr. Wiley's suggestion is good. I'm a little worried about a creatinine. I'm also looking at the injection here. We're obviously in the true vessel from above, and I'm just trying to go a little bit below, follow the crosshair down. So I'm going to probably pull back my crosshair here or pull back my wire, but the problem is I'm not able to get anywhere from above except to the point where we know we're not in the true lumen. So over here we know that if we go medially we're not in the true lumen, and we know if we go laterally we're not in the true lumen. The only question is whether to try to get a support catheter here from above, which is what I'm going to try next. Can I get a new fine cross, guys? How are we doing with time, George?
We have essentially completed the 60 minutes from the allocated time, but we had a little bit of a delay in the introduction up front, so we have a couple of minutes for the 60 minutes, so it's essentially up to you when you want to call the transmission. From my point of view, I would keep it for another 5 minutes for sure.
Yep, I'm gonna keep trying to go here.
Yeah, okay.
You know, but my point is also when to, you know, we're gonna keep working even off air, and we'll archive whatever we do at the end.
How much dye thus far?
It's just you know, at this stage, I think it's just going to be pretty rudimentary what we're going to do. We're going to try to keep going from above and below with different wires. I think Bruce has very elegantly described all the techniques that we could use here. At the same time, it's also a question of watching her renal function, watching the amount of dye that we do, and you know, we know that she has gone into acute renal failure a few times. We did admit her and hydrate her. So I think we're gonna end the transmission here now, and then what we'll do is we'll archive whatever else that we find.
I think that would be great to archive it. How much dye so far, PK, and what type of dye have you used in this case?
We always use VisiPake here. We've given about 160 ml of dye. We use the assist device. So you know, at this stage, I think, you know, with our recent renal failure, we're going to stop here with 160 of dye, and we'll go ahead and you know, we'll go ahead and archive what it is we do and give an update on this. So I want to thank you, George, and I want to thank Dr. Gray for coming here all the way from South Carolina and helping us, and obviously Dr. Wiley. And you know, we'll archive this, and I hope it's been helpful in some of the techniques that we use. And you've also seen a lot of the difficulties that we can face. Now, we do quite a few of these cases a year, as does Dr. Gray, but clearly some you succeed, some you fail. But more importantly is the technique. And we're going to keep working, and we'll definitely give you an update on this patient.
Well, thank you, PK and Bruce and Jose for this great effort. It was a really unbelievable, challenging case of not only infrapopliteal disease, but also these limitations regarding dye load and and possible renal failure complications, etc., that all of that make the right choice to give it a full go and choose the right time to quit as well. And we will archive this case and including the final result of it at www.peripheраlinterventions.org. You can email us some final comments at the email info@peripheраlinterventions.org. I'd like to thank you all for attending this webcast and to also remind you that in the live peripheral interventions webcast of Mount Sinai Heart will continue monthly with the same exact team, the fourth Wednesday of every month. The next one is on February 22nd at 8 a.m. Eastern Standard Time, and at this point, so long. I'll see you back on February 22nd.